So thank you very much for joining. So this is a talk for pediatric board. They asked me for this topic, although I have given this topic before. So I think I'm listening to my record. Let me close it. Okay, so I'm actually repeating this topic. Maybe some of you had heard me doing this talk before. So, but I'm repeating it based on the request of my colleagues. The objective is to give you some introduction, and we'll talk about mechanism of action. And then we will talk about specific antimicrobials, and we'll also talk about other antibiotics choices and other issues with the antibiotics, especially in the neonatal period. So as you know, and I'm sure you know, that we have two types of antimicrobials. We have bactericidal and bacteriostatic. Both of them end in death of bugs. But the bactericidal kills the bacteria, while the bacteriostatic interfere with the growth. And that either arrest the growth or interfere with the immune system and lead to the ultimate goal, which is the killing of the bugs. So there are many ways that antimicrobials work. The first one is inhibit the synthesis of the cell wall. Example is penicillin, cephalosporin, carbapenem and monobactam and vancomycin. It either also inhibit the protein synthesis by inhibiting the 50S subunit. Example of that is macrolides, clindamycin, and linezolid. And as you see that those who inhibit the 50S subunit to prevent protein synthesis, usually they are broad spectrum. They cover many antibiotics, and that's why we use them, for example, for soft tissue infection, for some resistance bacteria, and so on. Some inhibit 30S subunit. Example are Aminoglycoside and Tetracycline. Some of them interfere with the synthesis of nucleic acid and function. An example, it's either inhibit the folate. An example on that is the Trimethoprim sulfamethoxazole, or inhibit the DNA gyrase. An example on that is the quinolones and the ciprofloxacin. So any of the board trainee, do you have any questions so far? I mean, is this information new to you? Do you know the information? Do you have any comment? Do you hear me? Hello?
Now I hear.
Yes, we hear you.
Okay, so any of the board trainee, Mustafa, Roa, do you guys have any question? Any comment, Abdurrahman?
العفو أستاذ. بالنسبة للسبروفلوكساسين قبل كان بالتكست القديم أنه ما يعطى قبل 18 سنة. حاليا أكو
We will talk about this, but about the ciprofloxacin, when and how to give and how to select. But I'm asking about the mechanism of action of antibiotics. Do you have any questions so far? But we will talk about specific antibiotics, each one.
Sorry, regarding trimethoprim, this mechanism of action interfere with the foliar synthesis in a human also, يعني? Thank you.
Yes. It's the mechanism of action, whether in a human And but this is very good question, Dr. Abdurrahman, because we always talk about antibiotic stewardship and trying to minimize the antibiotics in the hospital and in an ICU or a PICU, and we do stewardship and prevent overuse of antibiotics. But believe it or not, the overuse of antibiotics is actually outside the hospitals, and the most of the resistance occur outside the hospital from overuse of antibiotics in the veterinarian, in the factories, in the manufacturer. So to answer your question, trimethoprim sulfamethoxazole is the mechanism of action wherever you use it, whether in a human or outside of human, or also use it in the manufacturer. And believe it or not, sometimes if you test the river, you will find some antibiotics.
Thank you, Doctor.
Okay. Others that interfere with the nucleic acid synthesis and function is reduce antibiotics with free radicals such as metronidazole. Okay, so let's speak about antibiotics one by one, and let's start with penicillin. Now, penicillin, there are many types of penicillin. We have the benzathine penicillin, we have the penicillin G, we have penicillin V, and we have ampicillin and amoxicillin. They are not much difference. We have amoxicillin clavulanate to extend the action, and we have ampicillin sulbactam to reduce the resistance. We have the nalthicillin, oxacillin, and floxacillin. We have the piperacillin and ticarcillin, and we have the piperacillin in combination with tazobactam. So we also have the cephalosporin as part of beta-lactam antibiotics. And as you know, the cephalosporins are of 5 generations. We have generation 1, which is the cefazolin, the IV, and you have the cephalexin or the Kiflex, which is the oral. And we have the second generation, which include the cefoxitin, which is an IV, and cefotitan, which is IM and IV. We have cefuroxime, which is oral, and we have the cefaclor, which is oral also. The third generation, mostly IV, such as ceftriaxone, cefotaxime, ceftazidime, and we have the cefpodoxime, which is the oral, and we have cefixime and cefdinir. The fourth generation, including the cefepime, which is IV, and the last, which is the 5th generation, is ceftaroline. We have also the Carbapenem that include Meropenem and Antibioics and Imipenem. We have also the Monobactam, which is the Azthronium. So let's start with penicillin. So as we said, the beta-lactam includes penicillin and cephalosporin. So benzathine is put with a preservative and carrier to make it very long acting. It is giving IM, and it's usually 1 dose or monthly dose, and you can use it even weekly dose, but that would be very high. And it is very painful because of its content carrier. We have the penicillin G and penicillin V. The penicillin G is the parenteral, either IV or IM, and the penicillin are very specific action antibiotics against streptococcus, against syphilis, and you cannot use it as first-line antibiotics because it's a not broad spectrum. It's a very specific antibiotics. So we use it for streptococcus, for example, group B streptococcus in neonatal period, or group A streptogenus in pneumonia. Or we also use it very recommended for 10 days of use of for syphilis. The penicillin V, the same action exactly, but it's oral. The ampicillin is having IV, IM, and oral, and amoxicillin are a broad spectrum antibiotics. They cannot be used for specific antibiotics. They can be used for non-serious bacterial infection, but when we use them for serious bacterial infection, we usually use them in combination with other antibiotics. They are very active against the gram-positive and also anaerobes. They active against both group A and group B streptococcus, and that's why we use them in the neonatal period. But because they are broad spectrum, we use them in combination. The antibiotics such as penicillin are very active against syphilis. All penicillin are active against meningococcal meningitis and meningococcemia. We use it in periodontal infection, anything associated with teeth infection. Sometimes they work against some gram-negative bacteria, such as Listeria monocytogenes. And that's very important reason for using it in a neonatal period. But usually when we use it for guessing therapy, we go for broad spectrum, not the specific one. We use it against Enterococcus, and we use it in acute otitis media. Also, we can use it in community-acquired pneumonia, not the pneumonia acquired in the hospital. We use it for E. coli. However, it's very important to remember, especially if it's a community-acquired UTI, not in the hospital, not a surgical, you can get lots of resistance. So let's talk about amoxicillin and clavulinate. They are oral. Example of it is the augmentin. So the amoxicillin clavulinate, it increases the beta-lactam inhibition, and that's why it decreases resistance. So it's very important to use in acute otitis media, in sinusitis, and it's active against MASA. So this is outside the context of the talk. So we have the bacteria is two types. We have the strep and we have the staph. The strep, either beta hemolytic or alpha hemolytic. The beta hemolytics are of two types, group B, and usually associated with baby, and group A, which is usually adult after neonatal, A adult, that's like the way you remember it. And group B, also called Streptococcus agalacea, and they're very commonly inhabitant the female genitalia and very common cause of group A is many types. We have the Streptococcus pneumonia and the Streptococcus pyogenes or group A. And we have the staph. The staph are of two types, the MESA and MRSA. MESA is the multi-drug sensitive Streptococcus, and MRSA is the multi-drug resistance Streptococcus. The MESA can be staph, but also can be non-staph. The staph from non-staph depend if there is a coagulase. So if you have a coagulase, then you can invade the tissue. And if you have a coagulase, you either MESA or MRSA. But some of the coagulase negative are also, as an example, they are inhibitant in the skin. So we have the Staphylococcus epidermidis, Staphylococcus albus, Staphylococcus saprophyticus, and so on. There are many antibiotics. The amoxicilin are also very good against the Pastorella and Staph aureus, and therefore are very important for animal bite. But they are not good for human bite because the human bite contain more bacteria in our mouth than the dog, believe it or not. So a human bite is more dangerous than actually the dog bite. Ampicillin sulbactam, example are unicin, and this is make it more wide spectrum to be used, and that's why we can use it. Same of clavulinate to increase the beta-lactam inhibition, but because it's a wider, we can use it with aspiration pneumonia, because aspiration pneumonia contain multiple drugs. Now, remember when we talked about staph, which drug appropriate for human bite? Yeah, we will say, we'll talk about that. Yes, we'll talk about that. That's a very good question. I forget to say, in MRSA or MESA, any staph who has coagulase, then they can invade tissue. And that's why when we have a staph pneumonia, for example, that is coagulase, it destructs the tissue, it eats the tissue. So it is not inflammatory disease. It is destructive disease. That's why it sometimes ends in abscess. So, and that's why when we extend, okay, somebody is texting me. Okay, not important. Okay, so that's why when we extend it more, the ampicillin, we can use it in lung abscess. We can also use it for animal bite, and we can use it for a community-acquired pneumonia. Now, if you ask me what is the difference between community-acquired and hospital-acquired, of course, it's the difference of the environment, and that's why difference of the types of bacteria, and therefore difference of the antibiotics. The nafcillin and oxacillin, the nafcillin is IV, oxacillin 2 form IM and IV, and both of them are parenteral. So both of them can be active against MESA or a streptococcus, staphylococcus that is not resistant. We can use them for osteomyelitis, we can use them for meningitis, and we can use them for endocarditis. The piperacillin, ticarcillin, or piperacillin with tazobactam, such as Zosyn, or Zosyn, sorry, they're very good active against Pseudomonas. They're also extended to gram-negative. They're active against Staph aureus, MESA and MRSA. They're active against anaerobe. And therefore, they are not a guessing antibiotics. They are not first-line antibiotics. They have to be used in a specific situation. And they're very important when we don't know the antibiotics, the bacteria. So they are very good in intra-abdominal abscess and for acute aspiration, like exactly the Clindamycin. So when you have aspiration pneumonia and we don't know the cause, then or we have intra-abdominal abscess and yet we don't have the cause, they're very good start, because they have penicillin action against the gram-positive. They work, but they are also anti-Pseudomonas, and they have a little bit of a gram-negative function, and they work against staph, and they work against anaerobe. So they're very important in air-deprived environments such as abscess. And because they are very wide, they are they're very good for aspiration, but they are not a guessing, because they're very important antibiotics and they should not develop resistance, and therefore they are not a good first line or a guessing therapy. Now, when we have penicillin allergy, we have two types. We have the type 1 or immunoglobulin E mediated, and usually, as you know, these are present with rash or itching, and they develop within few minutes. But remember that the rash and itching with antibiotics does not mean it's always allergy. It can be a side effect of the drug itself, because any drug can cause rash, and that's why it does not mean that there is rash, that there is allergy that you need. But when we say allergy, it's either immunoglobulin E mediated or globulin G. If it's globulin, it's usually associated with at least other symptoms, such as respiratory involvement or GIT involvement or cardiovascular involvement. So they present with hypotension, we present with bronchospasm, angioedema, urticaria, in addition to the rash and maybe itching and edema. So please try to, when you say allergy, now I said allergy, is it immunoglobulin E or immunoglobulin G mediated? So very important. If it's neither, then it's a rash and itching due to side effect of the drug other than, by mechanism other than allergy. Now, immunoglobulin G, it's a late, so it can present with urticaria, fever, arthralgia, arthritis, like serum sickness, exactly. Now, let's move to cephalosporin. Now, the cephalosporin, as we discussed, is of 5th generation. The more you go to the 1st generation, the more you are gram-positive effect. The more you go to the 5th generation, you are more to gram-negative effect. The 1st generation, we have 2 types. We have the cefazolin, which is the IV, and we have the cephalexin, which is oral. And they are work very good for gram-positive, but they have no effect on the MRSA. So remember that. And they are very good for skin and soft tissue infection. But you have to remember that they are not good against the staph, the MRSA staph. So if you suspect MRSA, then it's not a good antibiotics. You need to select. If you want to use oral, then you go for Clindamycin, or you go for Trimethoprim, or if you need IV, then you have to go to Vancomycin and so on. So remember, when you suspect MRSA, these are not the good choice. The 2nd generation, we have oral and IV and IM. So we have the cefoxitin, cefotitan, cefuroxime, and cefaclor. And in addition to the gram-positive, they are very good against anaerobe. And therefore, they are very good in infection that is deprived of oxygen, such as abdominal surgery, such as the sorry, I mean, the font has been changed. I don't know why. So also pelvic inflammatory disease, and they are very good against community-acquired pneumonia. Now, when we reach the 3rd generation, we become both gram-negative and gram-positive. Now, there are very strong belief that I don't know from where it came, the use of the cefotaxime. Some people think that cefotaxime is a strong antibiotics, and therefore they use it when they have suspicion of serious infection, which is absolutely incorrect, because the cefotaxime is a weak antibiotics, because it's neither gram-positive nor gram-negative. It works against, but it's not as good as 1st generation against gram-positive, and it's not as good as 5th generation against gram-negative. The good news about cefotaxime and the 3rd generation, they have Pseudomonas effects such as ceftazidime. The 3rd generation, they are not good against MRSA. So please remember, if you suspect MRSA, this is not good antibiotics. If you have a serious bacterial infection, you cannot use them alone. And they are not the super antibiotics. So please remember, when you have a sick baby, to think twice before using them. Example of them is ceftriaxone. It's a little bit long action, and it looks a little bit associated with hepatitis or jaundice. The cefotaxime is a short acting. Ceftazidime have anti-pseudomonas. The cefpodoxime is the same but oral. Cefixime have cefdinir, almost same action. They are very good for meningitis because they can invade the meninges. They are very good for UTI, pneumonia, and if you have a suspicion of pseudomonas, you can use the ceftazidime. But please remember, if it's you think of MRSA, then you should not use them. The fourth generation, they are more gram-negative. So they're way better than third generation if you suspect gram-negative, but still they work against gram-positive, but they are more gram-negative. And the fourth generation, such as cefepime, also active against Pseudomonas. The fifth generation, the good news about them, they are very good against gram-negative. They still have work against gram-positive, but the difference here, they have some MRSA effect. And that's why when you have MRSA, their suspicion of MRSA, they are way better. Do you have any questions so far? Do you enjoy the session? Is it good? Is it bad? Is it complicated? Is it slow?
I have no question.
Is it slow? Is it fast? Is whatever you have comment, please tell me.
It is informative.
The board trainee, any question? Okay, let's go. Okay. So some people think that cephalosporin actually cross-react with penicillin. So if you have allergy to penicillin, you might have allergy to the cephalosporin. And this cross-reactivity are higher with the first generation, and they get lower and lower, not higher, I mean higher in incidence with the first, not in severity, but when they are coming, it's the same. But they have a higher incidence with the first generation, but the incidence goes slower and slower once you go to the higher generation. It is very, though it is there, but it is very rare with the cephalosporin and not as common as penicillin. Now we will be talk about the carbapenem. Example are meropenem, ertapenem, and imipenem. Now the meropenem, sometimes they combine it with the cilastatin and the antibiotics called Trimethoprim. Now it's very important to remember that this bacteria, these antibiotics work equally to gram-negative and gram-positive. And it's very important to keep these antibiotics for rare diseases. And it's very important to remember to use these antibiotics with blood culture and use it only when you have sensitivity to meropenem, because it's super important antibiotics. And now if you use it and you get resistance, you probably have no other choice, and you develop what we call it super bug. So the meropenem is a little bit more expensive than imipenem, but the imipenem, they say it is associated with seizure. So always the meropenem is preferred. The ertapenem, I don't have experience because I never used it. So because it's a very wide spectrum, and it's against Bacteroid fragilis, Enterobacteriaceae, Pseudomonas, against Listeria, against Enterococcus fecalis. That's why it's very important for the intra-abdominal treatment, such as peritonitis, abscess, severe unresponsive neck, and it's very commonly we use it as a third generation or a third line in neonatal sepsis.
عفوا أستاذ سؤال إذا مو زحمة.
Yeah, go ahead.
إذا أكو suspicion للسيدوموناس infection البتر يكون تشويز الميروبينم لو السيفتازيديم third generation of cephalosporin which is more effective.
No, it depends how sick the baby. The ceftazidime and piperacillin are specific on Pseudomonas. So if you have Pseudomonas, these are better than meropenem. Meropenem is active against Pseudomonas, but it's active against wide spectrum antibiotics. So if you have intra-abdominal infection, the blood culture will not reflect 100% what is in the abdomen. So you might have, for example, Pseudomonas in the blood, but in the peritoneum, you have a different bug. You might have more than one. And that's why when you have intra-abdominal problem, meropenem is preferred. But if you have no intra-abdominal problem, but you have a blood culture with Pseudomonas, then better to use the anti-Pseudomonas such as ceftazidime or use piperacillin or ticarcillin. Now, the problem with piperacillin and ticarcillin, they are very irritant, so they need better central line, or you can use it with the peripheral line, but you can more peripheral such as anticubital, and it need to be used over a long period of time with lots of fluid. So this is another side effect. Meropenem does not need that. You can infuse it over 30 minutes.
شكرا جزيلا.
Is it clear?
Yes.
Or it's complicated?
لا واضح يا أستاذ عشتيلك.
Thank you. Okay, so monobactam such as Astrionum or Astrionum, mostly we use it when we have allergy to penicillin, and we cannot use aminoglycoside because of an ear problem or kidney problem, or baby is very sick and have high creatinine level. It's a very good against gram-negative bacteria, and it's a very good against Pseudomonas aeruginosa and Enterobacteriaceae. Now remember that the monobactam does not work on gram-positive and does not work on anaerobe. They are not good choice for intra-abdominal infection. Very important to remember, in a contained infection in oxygen-deprived area, they are not good. Clindamycin. Clindamycin actually is a very good drug because it's a very wide spectrum and it works against the anaerobe, and it's very good against MRSA, and it works against staph and strep. So it's very good for tissue infection, for soft tissue infection. It inhibits cell wall synthesis by binding to 50S subunit of the ribosome. Okay, but they have many problems. First, they very commonly associated with esophageal ulcer. Second, they can cause red man syndrome. Third, they can cause also diarrhea caused by Clostridium difficile. So clindamycin are very good for soft tissue infection, for aspiration pneumonia. Okay, but remember their side effect when you decide to use clindamycin. They are very good for teeth-associated infection, very good for soft tissue infection, very good for a human bite. Aminoglycoside, we have the gentamicin, we have tobramycin, we have the amikacin, and we have the streptomycin. Now, gentamicin are very commonly used, mistakenly. I don't know why people like it and use it, very common. So that's why I have lots of resistance. The aminoglycoside works by inhibit bacterial protein synthesis by binding to 30 subunit of the ribosome, and therefore they are not bactericidal. So they are rarely beneficial alone. They need to be combined with someone, and they have lots of resistance. So they should not be used with any community acquired disease. And that's why, for example, in neonatal sepsis, we use ampicillin gentamicin when it is inborn. But if the baby went home and developed some problem to rule out infection, gentamicin is not a good choice. So let me answer my phone and I come back to you, please. 1 minute. دكتورة رانيا، وانت بألف خير وصحة وعافية. لا تأمريني. لا بالعكس تأمريني. نعم. 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 واو. A stool passed from a boy or girl? No, pass or not pass? But who? It's a boy or it's a girl? It's a boy. Pass urine or not pass urine? So did you check the anus and there is no anus? Oh, okay. So okay, so you, well, they need surgery. If there is no opening, it needs at least colostomy. So you need to contact Sharif. Do you know Sharif? في دبي. Need to be transferred to Dubai. كاش يسوي لك شو دخل؟ هم ينجزون. او ملقاي قاسمي، عندك محمد حسن وعندك خالد خلفان في القاسمي. محمد حسن. There is no problem. It's يعني كم ساعة عمر البيبي حاليا؟ Not examined. This is the first time we examined the baby is normal. ما بيها شيء. شو دخل هي imperforated anus. Imperforated anus, you cannot, it's not an urgent surgery, it's not life-saving urgent. اكو اذا اكو شو اسمه، اذا اكو فيسكس ما راح يسوي له شيء، وحاليا راح يسوي له كولوستومي ما راح يسوي له شيء. لا ما يزعل الموضوع ابدا. خليهم توتري، شو دخلك انت؟ شو دخلك انت؟ imperforated anus, it's a congenital mal. ولا يعملون اي شيء، ولا يعملون اي شيء. انا بس اخلص السيشن اقول لك شو نسوي. This is the baby is normal and the first time examined did not pass stool. وامتى الساعه كم اكتشفتوه بالضبط؟ شو الساعه ميش انولد هو؟ الصبح قبل يوم. ومنو اللي كتب باس ميكونيوم؟ مو مرتين. سالتيهم شفت الميكونيوم ولا؟ ممكن اكيد هو maybe he passed the meconium through the anus with the urine. Maybe he has fistula, rectovesical fistula. But maybe rectovesical fistula. Yeah. So انت كتبي الجسم on the first examination the baby discovered to be imperforated anus and need referral. واتصلي مستشفى القاسمي حاليا عندك دكتور خالد خلفان وعندك دكتور محمد حسن. تريدينا يعني بعد ما اخلص انا ممكن اتصل لك بخالد خلفان او اعطيك رقمه يعني. اي بس اخلص عندي سيشن ماشي. شكرا. ماشي بس اخلص واجي. ماشي شكرا. Sorry about that. We have an imperforated anus, so I have to. Okay, so let's go back. So the most important point about gentamicin is nephrotoxicity and ototoxicity. And that's why if you needed more than 3 doses, you need to check the level. Again, it's active against gram-negative bacteria such as E. coli, Yersinia, and Fractionella tularensis. And that's why it's, both of them are good when you have a human bite. They have some activity against staph. And especially against staph, they are synergistic with the ampicillin. They can work also some against mycobacterium, such as Trimethoprim, and Entamoeba histolytica, such as the gentamicin and tobramycin. And also they are good for Cryptosporidium pavum. Now, the amikacin are very good for community-acquired infection, while gentamicin is a good choice for hospital. We use it for neonatal sepsis. We use it for endocarditis, tuberculosis, streptomycin, complicated intra-abdominal infection because they're wide spectrum, complicated urinary tract infection. It's always when you need it. Most of the time you combine it with other. And it's very good for nosocomial respiratory tract infection or hospital-acquired infection, such as strep or even staph. And it's good for, again, as the plague. Now, when we check the level, usually I check the level before the 3rd dose. Now, I'm very interested in the trough. I don't like the peak. So I usually don't look to the peak. However, the best is to do the trough and the peak. So the trough normal level is 0.5 to 2 mic per mil, and toxic is more than 2. So if you have the level high, more than 2, and the trough is you stretch the dose. So if you're giving it every 24 hours, you give it every 36 hours. If you're giving it every 8 hours, you give it every 12 hours. If you're giving it every 8 hours, you give it every 12 hours. If the peak is high, if the peak level is high, you decrease the dose. Okay, so the trough level is 0.5 to 2 mic, the normal. The peak is about 8 to 10 mic, and the toxic is more than 12. You have 2 options, increase or decrease the dose if you're dealing with peak, stretching or shortening the duration of antibiotics if used. I rarely use the peak, but I always use the trough. Any question?
No.
Okay, so macrolides, example are azithromycin, clarithromycin, and erythromycin. They inhibit the 50 subunit of the ribosome, and they increase the motility. And that's why some people use it in certain situations, other than being antibiotics. So they are very good against gram-positive. Limited gram-negative. Some people use it for H. pylori because they are motility agent. Pertussis, mycoplasma, and chlamydia. They cause GIT irritation. They can cause hyperpyloric stenosis if the baby is below 1 month. They are increasing risk, but they are not direct cause because they are motility. We used to use them with the prophylaxis, eye drop prophylaxis. And I think many hospitals are practicing this, but this is actually, by evidence, is not required anymore because they are not active against chlamydia. and their use against other bacteria are of limited. So we used to give some chemicals such as silver nitrate to give the drops, and then we start any babies, we give erythromycin. Even in our hospital they give it, but if you look at the evidence are very weak, and the most important is to treat the chlamydia, and these bacteria or these antibiotics are not active against chlamydia, and therefore the advice is only if you have positive finding is you give one dose of for example cefotaxime, or you give penicillin, or whatever the antibiotics you select to use. It's way better than using the prophylaxis of erythromycin. Rifampicin is very important to be used in tuberculosis, and also it is very important for invasive we have the invasive Haemophilus influenzae, and it inhibits DNA dependent RNA polymerase. It is being used in a close contact of patients with meningococcal infection, and it's used with combination or with vancomycin with certain staphylococcal infection. Therefore, it's very good for VP shunt, osteomyelitis, and endocarditis. We use it also for persistent group B, group A streptococcal pharyngitis in combination with beta-lactam antibiotics, and it's very important for MRSA carriage. It is cause discoloration of the secretion, such as red-orange body fluid and hepatotoxicity. The fluoroquinolones, example ciprofloxacin, ofloxacin, and levofloxacin, and gatifloxacin, they inhibit the DNA-dependent RNA polymerase. They work against multi-drug resistance, and they should be restricted to only when the other antibiotics are resistant and the other IV antibiotics working against one bacteria is not available, and the parent should be informed and better to take consent, and the very good are against MRSA carrier. They're very good against UTI multi-drug resistance gram-negative routes. They work very well with Pseudomonas aeruginosa, and they're very good in difficult infection by Pseudomonas, such as in the nails, and they're very good in the areas or tissue with limited blood supply, such as chronic or acute osteomyelitis. Tetracycline and doxycycline, these medications are very common with tick bone and Properiobactam acne and MRSA. They inhibit the 30S subunit of ribosome, and they are not preferred against in patient below 8 years because they cause permanent dental staining. Trimethoprim, it inhibits folate synthesis pathway of the DNA and protein synthesis, and they're very good in UTI, in methicillin resistant staph, and in Pseudomonas gyrovesi, pneumocystis gyrovesi, and in Shigella and Salmonella gastroenteritis in Burkholderia, Sebacia, and Procilla, and they're very good in soft tissue infection. They're very good in soft tissue infection, and they're very good because they work against MRSA. But the main issue is with me, I cannot use them in the neonatal period because of their side effect. Vancomycin are very important antibiotics. They are, this is a specific target antibiotics, and this is inhibits cell wall synthesis, but it causes ototoxicity, nephrotoxicity, resistance with misuse, and can cause red man syndrome. We need to monitor level, and usually I check the level before the 5th dose. It needs to be given very slowly, and if they develop side effect, we can use the diphenhydramine to treat that side effect. So I check the trough prior the 5th dose, and so I only use it. I don't check the level with the rule out infection, but I use it with documented infection because I need to use it for a long time. So usually when the level is 15 to 20, the minimal inhibitory concentration is usually more than 1 mic per mil. If your level is 10 to 15 mic per mil, the minimal inhibitory concentration is usually less than 1. We use it for a neonate for confirmed or hardly suspected MRSA infection. And that's why it's important as a second-line therapy in babies who are already giving the first line, the infection ruled out, and then you insert a central line, and then there is a suspicion of an infection, and there is already central line. So the likelihood of CLABSI, including MRSA, is very high. CLABSI is catheter-associated bacterial bacterial serious infection, CLABSI. So the normal level that I look is from 5 to 10. If the level is 10 to 15, usually is on a higher side, but if the level is 10 to 15, usually is acceptable level. If the level is 5 to 10, then probably is adequate in treated of the cones, such as coagulase negative staph, such as Staphylococcus epidermidis or ELBAS, enterococcal infection. But for MRSA, you need a higher level. Now, if the level is more than 20, okay, so you do trough level just before the prior dose. So if the level is high, you can prolong the dose, the duration, sorry. So prolong or stretch the period between the doses, or you can increase the dose by 20%. If the level is less than 5, it depends, less than 5 or less than 10, depending where you're using it, you can increase, either decrease the duration or increase the dose. Usually I increase the dose by 10%. So how we chose? For neonatal sepsis, I use ampicillin and gentamicin for inborn. For outborn, I use amikacin and cefotaxime. For second line, I use either gentamicin with vancomycin, or I use gentamicin with meropenem. It depends really on the antibiome of your hospital. For gonococcal conjunctivitis, it's better to use IV ceftriaxone. So if you're suspecting, if you have enough risk factor for conjunctivitis, 1 dose of trexazone, 50 milligram per kg is enough, or even a flat dose. And erythromycin is actually of no use. So it does not need to be used. It does not need to be used as the evidence of its use as a prophylaxis is very limited. For chlamydia conjunctivitis, we can use erythromycin. Again, topical are questionable. People use systemic. For meningitis, sepsis, first line, less than ampicillin, gentamicin. For meningitis, sepsis, second line, and less than 30 days, I use vancomycin and gentamicin, but sometimes I replace it by meropenem. Meningitis bacteremia from 30 to 60 days, I use ampicillin ceftriaxone. Meningitis bacteria more than 60 days, I use 3 antibiotics until I have the culture vancomycin, ceftriaxone, or cefotaxime. For streptococcal pharyngitis, we can use oral penicillin because mostly stripped. We can use benzathylene penicillin as injection one time. Dental infection, we can use oral penicillin. Again, streptococcus is the most common. Acute otitis media, we need a wide spectrum antibiotics. We can use amoxicillin or amoxicillin with clavulanate, or we can use the 3rd generation cefdinir, or we can use IV ceftriaxone. So, how we select antibiotics in neonatal sepsis? What is the meaning of minimal inhibitory concentration? The least concentration that kill the bacteria in the lab. That's the answer. Minimal inhibitory is the least concentration of the chemicals needed to kill the bacteria in the lab. Is it okay? Okay. So how we treat neonatal
العفو
sepsis?
أستاذ، ممكن سؤال؟
اتفضل.
بالنسبة للفانكومايسين أنا أقدر أستخدمها وحدها بدون combination؟
No,
لو يكون ineffective.
unless you have an infection. You start guessing therapy. So you start, for example, vancomycin with cefotaxime or vancomycin with meropenem, let's say, because you have a line. And then the bacteria came back and it's sensitive to vancomycin. Then you stop meropenem and continue with vancomycin. But for guessing therapy, vancomycin is a specific antibiotic, not wide spectrum, and it cannot be used alone, and cannot be used as a wide spectrum. So we use it when we suspect MRSA, such as you have a line, a central line, or for example, you have a lung abscess, or you have a destructive problem. So some tissue are being eaten because it's a coagulase positive. Okay.
تمام، شكرا جزيلا. Okay. عشت إيدك أستاذ.
So how neonatal sepsis to treat, you need risk and you need signs and symptoms. Okay. So neonatal sepsis, you need risk, you need symptom, and you need sepsis workup. The right term is to rule out neonatal sepsis, rule out sepsis. The correct term that we use, rule out sepsis, until we have bacteria in the blood. The bacteria in the blood called bacteremia, but because bacteremia with symptom, we call it sepsis. And some people call it septic workup. This is incorrect. Septic workup means your workup is dirty. Your workup is septic. The correct term is sepsis workup, not septic workup. So to treat neonatal sepsis, you need risk factors and you need symptoms and signs. If you have either of them, antibiotics are not indicated. So what are the risks of infection? The mother is in labor. So mother comes with labor pain. She is in labor. You have rupture membrane more than 18 hours, but for herpes, it's only 4 hours. Mother have fever. Mother have leukocytosis. Mother have uterine tenderness. Mother is GPS positive. Untreated. Urine or vaginal swab is positive. Previous neonatal sepsis. Previous unknown cause of neonatal death. Fetal distress. Fetal growth restriction. So these are risks. These are alone. They don't need antibiotics. They just need observation. And then you have symptom. The symptoms, if you give positive pressure ventilation for more than 10 minutes, any resuscitation that you exceed the first step of NRP. The first step is positioning, cleaning, stimulation, warming, and dryness. If you need more than this 5, okay, not stimulation. Stimulation is anything that is active, then you need to consider this as symptom of infection. Any baby born before 37 weeks, that's considered symptom of infection. So if mother is in labor and baby is less than 37, this baby need rule out sepsis. Baby have respiratory distress, poor activity, hypotonia, the abdomen is distended, vomiting, hypoglycemia, temperature instability, tachycardia, bradycardia, apnea, seizure, feeding intolerance. These are symptoms. So if you have both, then you do the sepsis workup, which includes CBC, you do culture, you start ampicillin and gentamicin if it's inborn, you start amikacin, cefotaxime if it's outborn, and then you wait 48 hours. If the culture is negative, or even there is no report, and the child is asymptomatic, you stop the antibiotics. If the culture is negative, but the child is asymptomatic, then you have to decide whether it's a culture negative sepsis or not. So what we have a risk or symptom, we don't have both. Monitor. So how you do CBC, you do vital signs, and you monitor the baby for 48 hours in the hospital. Now, is that clear?
Yes.
Okay, so what does that mean as a flow? So you did sepsis workup, you have culture positive, then you start antibiotics, and then you continue the antibiotics, and then you keep repeating the culture every 48 hours, and you look at your sensitivity, and you continue antibiotics depending on the type of bacteria for the duration specific for that bacteria, and you should have 2 days culture negative. So for example, if you decide to give 21 days for meningitis, you should give for 21 days, and the last culture that you've done should be at least 48 hours from your stopping of antibiotics. Is that clear?
Yeah.
Okay, then you send baby home. Now, if the culture sepsis is negative, so if your baby is symptomatic, then usually I continue antibiotics only for 5 days, and I repeat the culture again after 48 hours. If I have 2 culture negative and I gave the antibiotics for 5 days, then probably I'm very safe to send the baby home. Now, if you monitor the baby either risk and or have symptom, they don't have, you monitor, you did CBC, and you monitor the vital sign for every 6 hours, and you monitor the baby for 48 hours, then there is no sign and symptom, you send the baby home. Now, if there is sign and symptom, you do sepsis work. Are we clear here?
So we can stop antibiotics after 3 days or after 48 hours if the culture is negative.
If the culture is negative and the baby is symptomatic, if the culture is negative by 24 hours, the yield is 50%.
Yes.
So by 24 hours, if the culture is negative, there is 50 chance you still have positive bacteria. If the culture is negative by 36 hours, the yield is about 80%. So if your culture negative by 36 hours, you have possibility at 20%, you still have positive. By 48 hours, the yield is up to 96%. So you have 96% possibility your culture is truly negative. You still have 4% you might be positive. But if you add the CBC is normal and your culture is negative, the baby is asymptomatic. So if you combine all, probably your yield 99, but you will never be sure 100%. So if you are asymptomatic, your CBC is benign. I don't know if you do inflammatory factors. I don't do them, but if you do them and they are okay, and 48 hours culture negative, and the baby is asymptomatic, you almost 99%, you are true that your baby is negative. Now, if the baby is symptomatic and 48 hours is negative, I personally continue for 5 days and I repeat the culture at 48 hours. So if the second culture, also 48 hours, is negative, you probably are not dealing with infection. So if the child turn asymptomatic, you send the baby home. If after 4 days and you give antibiotics and you have 2 culture negative, you're probably dealing with symptoms not related to infection. So you have to find a PDA, a cardiac problem, lung hypoplasia, pulmonary hypertension, hypoglycemia. You have something else other than infection.
I thought TTN better in term babies.
I did not understand the question.
Transitory tachypnea.
What about it?
I had a baby with transitory tachypnea, but I had to put it on CPAP, put the baby on CPAP, and gave in an antibiotic.
Okay, so if you have a TTN and the baby is TAM, so what are the risks of infection, whether the mom in labor or not?
No, it was C-section.
Any fever?
No, just
Any,
TTN.
okay. What are the white BC count?
I just gave for 48 hours antibiotics and
it's not wrong. It's not wrong. But if I am, I will not give. But what is the CBC? What is the
all normal.
Sugar level is okay?
Yes.
Blood gas is okay?
It was 2.2 initially, but then all others were okay.
Okay, but you start IV fluid.
Yes.
Yeah, so you corrected it there. That might already hypoglycemia. So if I have hypoglycemia and then you have respiratory distress, so I have 2 symptoms, what is the white BC count?
It was 9.8, I thought.
So if it's more than 30 or less than 5, I consider it also symptom.
Yes, now
what about,
that was not positive. That was 9.8.
Okay, what about any previous history of neonatal death, sepsis? What about the GPS?
All negative. That was TTN. I sent the baby home.
Yeah, I know. So usually if I have no risk factors and baby is TTN, I don't start antibiotics. However, if you start antibiotics, you just stop it after 48 hours of culture negative.
Yeah, I did it that way. I wouldn't start too, but somebody else started and I had to continue for 48 hours.
Oh, sure. Yeah, not wrong.
Thank you, Professor. Excuse me for interrupting.
No, that's okay. So for acute mastoiditis, we use vancomycin and ceftriaxone or cefepime because this is very good against Pseudomonas. For preseptal cellulitis, trauma, that's mean outside the orbit, and that's the possibility of strep and stuff is very high. So we use cephalexin because it works against MESA. Clindamycin is very good against soft tissue. Trimethoprim is a very good broad spectrum and it's very good in soft tissue infection. In preseptal cellulitis, follow the sinusitis, so the streptococcus, non-typable Haemophilus influenzae, Moraxilla catarrhalis. We need to use more broad spectrum such as augmentin, cefdinir, or ceftriaxone, the 3rd generation. Pneumonia caused by streptococcus pneumonia, we can use ampicillin, amoxicillin. Pneumonia at school age, we need to use azithromycin or erythromycin. Osteomyelitis with staph suspicion, we can use nafcillin, cefazolin. For MESA, we need vancomycin, linezolid. For MRSA, we can add the 3rd generation if the baby is less than 3 years because there can be a combination. And the 3rd generation usually have more gram-negative. Osteomyelitis, Pseudomonas aeruginosa, such as in the nail, we use ceftazidime or ciprofloxacin if more than 12 years. Osteomyelitis, Salmonella, we use the cefotaxime and ceftriaxone. Osteomyelitis in immunocompromised, such as Kinji, we use ceftazidime IV or ciprofloxacin. For syphilis, again, penicillin. Other antibiotics might be used, but the standard is we can use benzathionesin also, but it's better to use 10 doses or 10 days of penicillin. For UTI, you need a broad spectrum, such as trimethoprim, cephalexin, augmentin, cefixime, cefazolin, cefotaxime, ceftriaxone, ciprofloxacin, all depend on the culture. Tissue cellulitis with MESA, cefazolin as an oral, cefazolin as an IV, or nafcillin. Tissue cellulitis, MRSA, we use methoprim, clindamycin, vancomycin, and linezolid. These are very important for soft tissue. These are for blood. This linezolid also for blood. Very expensive medication. So I think course will cost, one course I think in our hospital costs $2,000. So very expensive antibiotics, and most of the insurance company will not accept. Post-operative surgical prophylaxis, we use cephalexin, cefazolin, cefoxitin, imipenem, such as cilastatin, and Premaxine, piperacillin, tazobactam, such as Zosyn. Pseudomonas infection, we use ciprofloxacin, we use Astrionam, we use Tiftazidine, we use Cefivim, piperacillin, tazobactam, Zazosyn. Dog bite, because of Pasteurella, we use augmentin and ampicillin, sulbactam, such as Unacin. Dog bite, allergic to penicillin, we use clindamycin, trimethoprim. Human bite, we can use these more bright, wide spectrum antibiotics. Remember that cephalosporin, ampicillin, amoxicillin, clindamycin can cause diarrhea caused by Clostridium difficile or Clostridium difficile colitis, present with diarrhea, abdominal pain, anorexia, and fever, and the treatment is metronidazole and vancomycin. So I'm gonna actually stop here because this is about stewardship, and I think it's a long talk. So I'm gonna stop here actually because I took a long time. I think these are all for stewardship, so I'm gonna pass it, and I'm gonna stop here. Okay, so questions.
Ustad, can I give ciprofloxacin during neonatal period?
Ciprofloxacin in neonatal period?
Yes.
Why?
Or during 1 year of life, due to severe gastroenteritis or bloody diarrhea.
Sorry, wait. Severe what? Severe what?
Severe gastroenteritis, such as bloody diarrhea.
What do you mean severe? What severe gastroenteritis is?
Yeah, resistant to usual treatments such as ceftriaxone, or no response to antibiotic during 2 days.
انت اسمك ايش؟ مصطفى صح؟ I think Mustafa, you're confused totally. First, there is nothing called severe gastroenteritis on unresponsive. Which bacteria is the cause? Did you do stool culture, blood culture, or there is no culture?
No culture.
Ciprofloxacin is not indicated at all. Ciprofloxacin is a specific is not a broad spectrum antibiotics. You have to know the difference between gassing antibiotics and antibiotics. Antibiotics, ciprofloxacin is not a gassing antibiotics. Is a specific antibiotics. Is used for soft tissue infection. Is used for, okay, so is important for soft tissue infection. Is important for a combination infection when we don't know the cause, okay? But it's a specific infection. It's like a clindamycin. It's like a methoprim. But these ciprofloxacin, clindamycin, and they have very high side effect. So that's why they are not first line. So if you want to use first line gastroenteritis, amoxicillin is best drug. Now, there is nothing called severe gastroenteritis that is not responding to treatment. Gastroenteritis respond to IV fluid. They don't respond to, you need IV fluid, you need electrolyte, you need TPN, total parenteral nutrition, you need support. Gastroenteritis is not treated by antibiotics. Gastroenteritis actually aggravated by antibiotics. Now, if you do stool culture and the stool is positive and the blood culture is positive or negative, then you decide whether to use antibiotics or not. So first, there is nothing called severe diarrhea. The word severe is our severe gastroenteritis. there is severe dehydration, there is mild dehydration, there is moderate dehydration, and there is gastroenteritis. Okay.
نعم أستاذ، أنا يعني خان التعبير، القصد أنه بالبلادي دايريا.
Oh, bloody diarrhea, you need to do stool culture. Have you done a stool culture or no?
No.
Okay. Is the baby symptomatic? Yeah, and baby is sick or not sick?
Yes, fever.
No, fever is not sick, yeah, Mustafa. Fever, you give antiviral. Sick mean, what do you know what is mean? Anybody tell me what does sick mean? Anybody knows what is sick? When I say this child, you are sick, you want sick leave. What does that mean?
By general look, maybe, يعني, or by examination.
Okay, what does sick mean?
By general look, يعني decrease the activity.
So you, Ahmed, you are sick. What does that mean? You are sick today.
Decrease the activity, decrease feeding.
Which activity you do? No, you are sick today. What activity you do every day?
Every day?
You. What are you doing every day? You wake up in the morning.
Call.
You eat your food, and
Yes.
then you drive to work. You go to the work, and
Yes.
then you finish, and then you go home. If you are not able to do any of these, you are sick.
Okay.
So what are the baby usually doing every day?
Yeah.
Yeah, Mustafa.
نعم أستاذ. Feeding.
What you feed the baby? What else?
Feeding and playful.
Play. No,
Yes.
but what else the baby do other than being playful?
Sleep, feeding.
The baby sleep. Okay. What the third one?
Feed.
Cry. The baby cry.
Okay.
Okay. So the baby feed, sleep, cry. What else? Passing stool, passing urine, gaining weight.
Okay.
Okay. So if the baby cannot do any of these, the baby is sick. Maybe he has rapid breathing, but he's not sick because he's feeding and he's crying. Maybe he has a fever, but he's not sick. Do you understand?
Yes.
Yes.
So the level of sickness determine what you will do. So if you have a bloody diarrhea, but the baby is not sick, okay, the baby is still feeding. But if the baby is not feeding, then you have to decide to give antibiotics or not, depending on the situation. So what are the causes in the community? Mostly if you have diarrhea, because diarrhea, you can have Entamoeba histolytica, you can have Giardia, you can have rotavirus, all cause bloody diarrhea. You can have Shigella, you can have Salmonella. Shigella and Salmonella in the you don't treat, but you have sick or not, that's one. Consider the community. Third is you have risk factors. If this baby at risk of sepsis, what are the babies who are at risk of sepsis? Do you know that, Mustafa? Being born premature, have history of previous admission, immunocompromised, abnormal test, leukocytosis, leukopenia.
Yes.
Inflammatory markers might help you. And then you decide which antibiotic. The best is when you do culture and decide, or blood culture and stool culture. Now, if you don't have, you go with broad spectrum antibiotics that have less serious effect, which are, do you know them? Ampicillin, amoxicillin. Okay. Methoprim if you are after neonatal period, but you don't use strong antibiotics serious and with serious effect, such as Clindamycin, such as quinolone, such as I don't know what other antibiotics, quinolone, Floxex, all these antibiotics that have a very serious side effect, you don't use them. Is that clear?
نعم. أشترك
Yes.
أستاذ. شكرا كثيرا.
Okay. Any question? Okay. If no question, then we'll see you next time. Thank you. Goodbye.
Goodbye.